So, thank you, Wayne. And so now we've talked about biology and we've talked about targeting. So I'm going to just give a general talk about concepts of treatment planning. So I just want to give maybe a brief history of interstitial planning concepts and talk about types of implants. And I want to discuss just in a general way how implants are evaluated, and then that will be discussed in gory detail in the second session today. So in terms of types of implants, there are intracavitary or intraluminal implants where the treatment is in an existing or created anatomical cavity. So we're talking about gynecological treatments, bronchial treatments, esophageal, and then balloon-based breast treatments where we place the balloon inside the seroma cavity. So that's a cavity that's been created within the patient. For interstitial treatments, needles or catheters are introduced into or through the skin. So we talk about interstitial breast or treatments of sarcomas. Prostate is a big one. Gynecological for different stages of disease, you could do that. And then there's surface brachytherapies, that's skin, and there's a mold construction workshop. And then on the right is actually we had to treat the sole of a patient's foot. And so we used an aquaplast head mask to make the immobilization device and guide our catheter placement to treat along the surface of the foot. So in terms of systems, so in the last couple summer schools, they discussed treatment, historical treatment systems in great detail. And so just historically, there's the Quimby system, and so sources were uniformly loaded throughout the implant. So a more modern practice with this would be an LDR iridium-192 treatment, so it'd be a low-dose iridium-192, where you're using the same source activity in each strand. You're not trying to preferentially load different activities into different strands. The disadvantage of the Quimby system is that it can lead to hot and cold spots within the implant. I would say a more modern practice is the Manchester or Patterson-Parker system. This is what we do now. We've been doing for peripherally loaded prostate seed implants, optimized HDR implants. You're going to hear a lot about optimization later on this morning. So those tend to load the activity towards the periphery of the treated volume, and that leads to a more uniform dose distribution within that volume. So to guide the treatment, and Wayne is going to be talking about this in just a few minutes, so there's templates that can be used to guide the needle placement. So, let's see. Oh, sorry. Start back. Okay. So on the left is a template used for prostate placement. So you have this template that is attached near the perineum, and the needles are guided into the prostate. In the middle is a breast bridge that's used to guide the needles for an interstitial breast treatment, and then that bridge gets removed, and the catheters or needles stay in place. On the right is a disposable Syed implant that, again, you can see where it gets sewn to the perineum, and this is used for gynecological treatments. And so all of these are used just to make sure that the needles get placed in a proper manner within the implant. Well, there's two different approaches you could talk about when you have an implant. So on the left, this is for a sarcoma treatment. So the catheters are placed parallel to the incision.
So in this way, you have fewer catheters, but the treatment length for each catheter can be very long. You can also place your catheters perpendicular to the incision. So in this case, you wind up with more catheters, but the treatment within each catheter is shorter. And how you approach this depends on what critical structures you're dealing with. So you might not want to use the perpendicular approach if there's a critical structure that will be passing close to the needle placement. Another thing to consider in terms of placement of your catheters is which end you're going to hook the transfer guide tubes up to. So this is an interstitial breast treatment, and if you look for the posterior side, well, it might be easier to hook the transfer, might not be as easy to hook the transfer guide tubes up from the lateral posterior side of this. But if you hook your transfer guide tubes up from the medial side, then they're going to be laying across the patient's face and the other breast. So you could get transit dose that you wouldn't want to give to the patient. To evaluate the plan, so we have our plan and we're talking about this, and this will, as I said, this will be discussed in greater detail later on this session. So Dorian Todor, who's faculty here, I've heard him say, dragging on isodose lines just makes pretty pictures. Certainly you should evaluate the isodose coverage of your treatment, but just dragging on the isodose lines to change your coverage might not be the best way to evaluate your plan. So each clinic and each treatment type should develop its own reporting schemes. So you can review dosimetric quality parameters, not just isodose curves. And as Jay was saying, EQD2 can also be reviewed, and we find this very useful for our fractionated GYN treatments. So this is not an endorsement of the Brachyvision system, but within Brachyvision, we have made custom reports for each treatment. So this is our custom report for a contour-based balloon treatment. So you can see we have our CTV, D99, D95, D90, D10. So we have some, we can calculate conformality indices. There's been some recent work that's saying that the D.2 cc of an inner 2 millimeters of skin should be reported for breast dose. So we've added that to our report, and we've developed these for each treatment that we do. I know this is hard to see. On the ABS website, there are spreadsheets for tracking EQD2 when we do this for our GYN treatments, for our cervical treatments. And so we have a column for the external beam portion that the patient has received. And then we update the CTV and the D2cc of the different bladder, rectal, and sigmoid structures. And we've actually had some good residents and other physicists who've automated this. So we have a report that gets printed out and then automatically read into this spreadsheet via a macro. So in this way, we're actually tracking our critical structure doses with each treatment. So we know if we're high for one treatment, we need to cut back for the next treatment. And we just track it to make sure we're within the guidelines. So in conclusion, I just wanted to provide a general background for the treatment planning process. The rest of the concepts that I talked about here will be developed in the rest of the session in greater detail: imaging, planning, optimization, evaluation, QA. Thank you very much.